Good afternoon and good morning to those of you who are now on the East Coast. My name is Janice Davis and I am here today with our colleagues from Nova Southeastern University in conjunction with the South Florida Geriatric Workforce Enhancement Program to present to you our first session of the 2022 Age-Friendly Public Health Systems 4M training for healthcare practitioners. Those of you who may have joined last year's session know that we did a deep dive into each of the 4Ms, and this year we're looking at putting the 4M framework into practice. So looking at case-based approaches to age-friendly health systems. And this is the schedule for the series. We are meeting, if you wouldn't mind, please muting your lines. We are meeting every other Wednesday for an hour and a half to look at different aspects of an interdisciplinary approach to having a 4M framework. And at the end of today's session, you will be able to understand the need and the importance of an interdisciplinary team for age-friendly health systems, and also understand why it is important to align medical treatment with what matters most to the patient. Our speakers for today, the welcome and introduction will be done by myself, Janice Davis. We will have Dr. Nishira Pandya from Nova Southeastern University presenting a recap as to why age-friendly health systems are important. And Jennifer Kwok from Kaiser Permanente will give a presentation of the interdisciplinary look at age-friendly health systems. My name is Janice Davis, and I'm the Age Friendly and Health Equity Program Manager at Urban Health Partnerships. And I have no disclosures to disclose. And I just want to briefly talk a little bit about our organization and our Age Friendly initiative for Miami-Dade County. So UHP was founded in 2011 with the vision that we co-design sustainable change in the community alongside community residents. We are really community-based health equity initiative throughout Southeast Florida. So we cover Summit Palm Beach County, Southern Broward County, and Miami-Dade County. We have a multidisciplinary team bringing a unique lens to our mission, which is to invest in communities by co-designing sustainable change and promoting equity and well-being across the entire lifespan. And we do this through community-driven leadership with three main initiatives: our Healthy Streets and Public Spaces initiative, our Food Access, Security, and Justice, the Age-Friendly Communities for Longevity, and they are all overlapped with the Building a Culture of Health Equity. A little bit about the Miami-Dade Age-Friendly Initiative. It's a collaborative effort to create a community where older adults can remain active, engaged, and healthy with dignity and enjoyment. We are focused on creating sustainable changes within the community to allow residents of all ages to age in place in the community, because we recognize the fact that Miami-Dade was not built with the population growing older in mind. Miami-Dade has over 500,000 older adults, and that number is expected to grow to over 800,000 by 2030. And we were not designed to have the infrastructure for both the amount of older adults and the fact that older adults are living much longer. We are a collaborative impact initiative led by 8 lead agencies, which are listed on the screen here. And we work mainly on policies, systems, and environmental changes to help redesign our communities so that way older adults can get the services that they need. We do use the livable domains livability, which are looking at outdoor spaces and buildings such as parks and recreation, transportation, including both accessibility and access to transit. Is it where the older adults live? And also, does it go where the older adults need it to go? Housing, both in terms of affordable housing and universal design for housing. Social participation, community support and public health system, communication and information, making sure that older adults receive the information that they need and the training on new technology, civic participation and employment, and respect and social inclusion. We currently have 13 municipalities in Miami-Dade that have signed on to be an age-friendly community, and we are working to get with 2 more communities to get signed on by this year. And what that means is that these communities have made a commitment at their town council or the city council or city commission level to really look at incorporating age-friendly activities, policies, systems, and environmental change into their community action plan. And they have a 5-year plan looking at how they can improve their community for the older adult residents that reside in that community. And it's part of the age-friendly social movement where we have our policy as the core. And as part of that, we have the age-friendly communities, which is where those communities that sign on to the age-friendly network reside, our age-friendly public health systems, our age-friendly health systems, which is what today's training is about, and our age-friendly cities. And with that, I am going to turn it over to my colleague, Isabel Edrande, to introduce our next speaker.
Hello, everybody. My name is Isabel, and I am the Health and Livability Project Coordinator at Urban Health Partnerships. And I'm very happy to introduce our next speaker, Dr. Pandya. Dr. Pandya is Professor and Chair of the Geriatrics Department at NSU, Kiran C. Patel College of Osteopathic Medicine. And she's also the Project Director of the HRSA-funded Geriatrics Workforce Enhancement Program. She is a Certified Medical Director and a Geriatrics Fellowship Program Director with an active clinical practice in which she teaches health profession students, residents, and fellows. Dr. Pandya is past president of the AMDA, the National Society for Post-Acute and Long-Term Care Medicine, and past chair of the Interdisciplinary Clinical Practice Committee. She has participated in the development of multiple clinical guidelines and position statements and is recognized for her work in the area of diabetes in the elderly. She is board certified in internal medicine, geriatrics, and endocrinology and metabolism, and holds the distinction of being a Fulbright Senior Specialist Scholar. So please join us to hear Dr. Pandya.
Okay. Can you see my slides?
Yes, but they are not necessarily in a PowerPoint. I don't know if that's how it's supposed to be.
Do you see the whole PowerPoint or 2 slides?
2 slides next to each other.
Okay. I have to get out of presenter view. Give me a second. Oh, is that better?
Yes.
Do you see 1 slide now?
Yes.
Yes, that's better.
Okay. Okay, so thank you so much, Isabel, for that kind introduction. And before we start, I have to acknowledge that our work is funded by Health Resources and Services Administration, which is part of the Department of Health and Human Services. But the contents, obviously, of this work are, and our views are our own and do not represent the views of HRSA. So I wanted to show you what our the GWEP, the Geriatrics Workforce Enhancement, consists of before we move on, and what our goals are. We have academic partners, Florida Atlantic University and Larkin University. We have graduate medical education partners, Aventura Hospital, Larkin Community Hospital, and Community Health Institute. They all train physicians in primary care and specialties. And on the lower left, we have primary care delivery sites, which are Cano Health, our NSU clinics, of course, and the clinics at Community Health Institute. And we have multiple community-based organizations, including yourselves and the Area Agency on Aging, John Knox Village, Alzheimer's Association, and so forth. These are program goals for the grant in general. And the first is to develop partnerships between academia, primary care, community-based organizations, which I showed you. The second goal is to train geriatric specialists, primary care providers, and all health profession students. So it could be nursing, physical therapy, medical specialties to care for the needs of older adults. The third goal is what we're going to focus on today, which is to transform clinical care environments, integrating geriatrics into the primary care setting to become age-friendly health systems. So I'll use AFHS from now on. And we are trying to position that into value-based care and to utilize alternative payment models. And then our fourth goal is to deliver community-based programs to patients and families to improve health outcomes. And the fifth focuses on similar training and delivery, but on Alzheimer's disease and related dementias. So the third goal for the grant is what we're going to focus on. I like this picture because it symbolizes to me what medicine is right now. We have organ specialists for every organ, and every different specialist tinkers with the body, but there are very few gatekeepers that take care of the whole patient, such as family medicine, geriatrics, internal medicine. So as said by the British Geriatric Society, we need to focus on more coordinated and planned care of individuals based on their goals and priorities, looking at the risks and benefits of treatment rather than different specialists simply focusing on their specialties. Not that that's not important, but I think the focus has gone into more specializing and taking care of various aspects of health, but not the overall health. What has led the Health and Human Services to fund projects such as this is the national shortage of geriatricians. Currently, the United States needs 20,000 geriatricians more to meet the needs of older adults, and yet only 7,300 physicians are board certified in geriatrics. And of course, we need to train other specialties. We need to geriatricize other healthcare professionals and direct care workers to take better care of older adults, because there really will never be enough specialists, and maybe all the care does not need to be in the hands of specialists, but we need to do better caring for older adults. And what I think everybody here is obviously vested in this is we need to add life to years. We need to invest in healthy aging, not as simply a massive cost to the country or to communities, but as an investment, because elders can contribute to the economy, to the workforce, to cohesiveness of families, and enrich our lives in general. So we have to rethink how we're taking care of older adults, recognizing at the same time that we all have biases, and there is still a lot of ageism in the way healthcare is delivered. And not only healthcare, there's ageism in the way services are delivered to older adults. So along with Urban Health Partnership and other organizations, we need to align health systems, public health, environmental and community services to meet the care, the needs of older adults. And of course, they may vary from community to community. So the goal overall is to help those people in our care to live a life that's as full and rich as possible. And I'll just do a little recap of what age-friendly healthcare is. This is an initiative from the Institute of Healthcare Information Improvement, IHI, and the John Hartford Foundation, based on these 4 evidence-based frameworks: what matters, mobility, medication, and mentation. And most of those speak for themselves. With mentation, we're looking particularly at preventing or treating or early recognition of dementia, managing depression if it's there, recognizing delirium. So those are the big 3 Ds. And mobility, we want older adults to negotiate the environment safely to maintain function and to reduce falls with injuries. Because as most of you know who are taking care of older adults, how you function is everything. And what have we learned so far? So we know that the demography of older adults is changing. In Florida, we are where the rest of the country will be in a couple of decades. We're already here with the number of older adults we have. So we need to look at improved ways of changing our approach to taking care of older adults, and to have a more holistic approach to take care of their comprehensive needs, and to lead to better patient outcomes and better satisfaction. Because although we have great healthcare systems and specialists, we're not really always serving the needs of older adults in providing the care that they need and that they require. And so this issue of what matters most is really important. And so why use this age-friendly approach? A systematic use of this 4M approach, addressing mobility, mentation, medications, and what matters most, has been shown in an evidence-based fashion to improve outcomes. Now, each of those interventions has improved outcomes. We're still studying whether all 4 interventions together can improve outcome. So most healthcare systems are now striving to get certification with the Institute of Healthcare Improvement and the Hartford Foundation. So at NSU Health, we've got level 1 recognition as an age-friendly health system participant. And of course, our goal is to move to level 2 as a system committed to age-friendly, care excellence. Not only can this provide better care for older adults, but obviously it can improve revenue for healthcare systems, because a lot of intensive work is required, care coordination, health maintenance is required for older adults. And one place where we could do a better job and try to incorporate the 4 M's is at the Welcome to Medicare or the annual wellness visit. Because here you actually have or should have time to address several preventive measures which I've listed here, like cancer screening, depression screening, looking at the risk of falls, bone density. And those also not only improve the care of older adults, but they will help health systems to have better outcomes. And obviously payment is important. And this will enhance our revenue and our payment, and also recognition amongst payers. So hopefully there will be preferred sites of care which provide better care for older adults, and we should then be able to attract more patients. Okay, so that's what we're striving for. So how can this 4 M's help? A simple way to look at it is what some of the adverse events that can be avoided. For instance, if you look at matters most, if you discuss what care patients actually want, you might, and what procedures they desire, what do they absolutely not want, or who's going to make decisions for them if they cannot speak for themselves. We might avoid unwanted ICU care, especially in this era of COVID. We might have reduced stays in the hospital. If we pay better attention to medications, review the list, deprescribe, remove drugs which are harmful or not beneficial, we might have fewer adverse drug events. And if we pay attention to mentation, people who have delirium in the acute care setting, or dementia or depression, we might have fewer adverse outcomes. And mobility, I think we promote mobility, detect patients who are at risk for falls. We could have less falls with injuries, less blood clots because of a sedentary lifestyle, pressure sores, and venous thromboembolism. So these are all very real places where care could be improved. We think that the use of this 4M framework is doable, it's measurable, and of course, some geriatricians and some settings speak of the 5 M's, and the 5th M is multi-complexity. I bet none of you have seen a geriatric patient with just 1 or 2 diagnoses, right? It's more like 7, 8, 9, 10 conditions. And I feel that nurses play an essential role in implementing this 4M framework, and the team working together is the key. No one discipline can do this together. And I know we'll hear more from Jennifer Kwok about this. And the benefits I've already alluded to, but we could also see fewer emergency room visits if we detect these preventable conditions and intervene in time. We might reduce hospitalizations, certainly adverse drug events, delirium, as I've spoken about, and falls and injuries. And so let me start with a little bit about these 4 M's. This is what matters most. Now, it's difficult. Well, so where do you start? What we have chosen for matters most is advanced care planning, but maybe there are better ways to look at this. Some prominent geriatricians have said, because geriatric patients are so complex, if you don't know where to start, why not start where the patient wants you to start? Why not ask them? Actually, I tried that a couple of times recently when I saw new patients. I said, what is your goal? What would you like us to do? And that was a thoughtful pause, but they said, I want to be on less medication. Well, that was a good place to start, So what matters most leads to the other ends, I want to stop falling. I don't want a wheelchair anymore. How can I walk better? So this might be a great place to start. And I took some examples of best practices from our last set of seminars. So Janice and Isabel, I hope you'll forgive me. I think you'll recognize this. But we had a nursing leadership from Anne Arundel Medical Center. And I was so impressed by how they carried out the what matters most part. Their whole care plan was driven by what matters most. And they talked to patients, they used stories, they brought pets in, they bribed and converted the healthcare professionals with food and gifts, but they achieved a lot of buy-in. They even used national publicity, local publicity with radio and TV stations, but they had passion, and the clinical champions were the nurses that made it happen. And then they also chose measures, like how are they going to see the effect of what they've done? They looked at readmission rates, the ease of discharge planning, and the length of stay of hospitalized older adults. And some of you will be familiar with hospitals that have acute care units for elders, ACE units, which can also focus on this 4M approach, but in a more concerted way. The other M, of course, is mobility. So maintaining mobility and function, even if you're hospitalized, even if you're in the ICU, you can be turned, you can be sat in a chair. Okay, so lying in bed seems to be the rule. I remember when I first started as an intern, I didn't know what order to write in the beginning. So I wrote bed rest was always my first order, but that was actually a terrible order to write. Okay, and then look at fall risk. Every patient has unique risks for falls. So always ask about falls at all visits. Patients don't often want to volunteer that. In the hospital setting, many hospitals have volunteers that involve health profession students who walk patients, who talk to patients, spend more time, get to know their families and their stories. And in the Anne Arundel Center, they used a mobility, a medicine card and a mobility card. They told the patient on the card what their medicines were, what they were for, and if they changed, the card changed. And they told them what they could do as far as mobility. And that really empowered patients. The other one is mentation. So what helps with dementia prevention and improving brain health? What we know from the evidence so far is that there aren't many treatments actually to treat dementias, especially Alzheimer's disease. There's now some drugs that are being released, but there's really no cure. And we think that nearly half the cases of dementia, especially vascular dementia, could be prevented. And so what are these strategies? Exercise has a positive impact. Walking reduces hospitalization, improves cognition. Mediterranean diet reduces the risk of Alzheimer's. A combination of cognitive training and strength training seems to be effective. and adequate sleep. So always ask about sleep as well, because sleep deprivation seems to worsen cognitive impairment. Now, the other M is medications, M for medications. So older people, I mean, it's shocking when we ask people to bring their medications, how many bags of supplements and bottles they bring, and yet they're reluctant to take some prescription medications. So always review the medication list. Look at to try to minimize anticholinergic medications, because they can cause urinary retention, confusion, falls, constipation. One of the common ones is Tylenol PM, because that has Tylenol and Benadryl, and it can cause delirium and confusion in older people. And as you know, not everybody's going to tell you what over-the-counter medications they're taking, all right? And then the medication cascade. Sometimes practitioners don't recognize a side effect as that they need to remove a medication. They think a side effect is another medical problem, and they add a medication to treat that problem. That's called a prescription cascade, and you want to avoid that. So always look with great suspicion at the medication lists every time they come in, every time they've seen a specialist, and so forth. There are lots of tools to help us with medication management. At the American Geriatric Society this month, we actually attended an update of the Beers criteria, which is coming out soon. So this is a list of potentially inappropriate drugs in older people, and that's being updated. But one of the crucial things was like aspirin. You know, people just take aspirin to prevent strokes or heart attacks. Well, the primary prevention use of aspirin. So if you've never had a stroke, heart attack, or any vascular event, and you're still taking aspirin, is shown to not be effective. And in fact, it can be harmful. Of course, aspirin is beneficial if you've already had a heart attack or stroke. Other medications that are culprits for side effects are long-term use of opioids, sedatives, sleeping pills, muscle relaxants, antipsychotics, and other anticholinergic drugs. So there is a movement in elder care to deprescribe. So what is deprescribing? It's the systematic use, assessment of every medication and discontinuation of drugs that are not effective or potentially harmful. Now, obviously, that can't be done unilaterally. You have to involve the patient, what their goals are, what their functional status is, and how this is going to affect them. And sometimes you have to do it with caution. So I want to now just jump into what we did to implement at NSU Health, our strategy for implementing the 4 M's. So first we tried to get buy-in from the clinical chairs of all our clinical departments and clinical administration. And initially there was a lot of enthusiasm. We hired a clinical trainer who is 0.2 FTE, who helps with training residents, students, faculty. She developed modules and integrated age-friendly training, and she and I presented to residents and fellows at their conferences, and we've trained about 155 residents and fellows in our different programs. She also provides hands-on training and like over-the-shoulder direction to clinicians on how to implement this, how to capture this when they're charting, when they're seeing patients in the electronic health record. And she's trained 35 of our clinicians and 115 clinicians at Cano Health, which is our big clinical partner. And we've had a lot of collaboration with clinical informatics. So we realized that documentation in the EHR is key, but obviously it has to be meaningful documentation. So on the right, you'll see where we think the annual wellness visit is preferable, where we can talk about advanced care planning, dementia caregiver support. These are all the merit-based incentive payment system measures that we're reporting on. So we think that the annual wellness visit captures the 4 M's as well as these MIPS measures, as we call them: false screening, medication management. That's all part of the 4 M's. And the other measures that we're reporting on is blood pressure control, glycemic control in people with diabetes, and screening for opioid misuse. Not that we're not using opioids, but we want to screen people who are on opioids and that they could potentially misuse it. And one of the tools we adopted the Institute of Healthcare Improvement tool for our clinicians on how to use the annual wellness visit. You know, check the medications. What tools can you use for depression? What are delirium risk factors, and so forth? Okay, how do you talk about what matters most? We have chosen advanced care planning, but I think they're also great surrogates on, you know, what is it that matters to you, your health, your transportation, your connectivity with families, using less injectable insulin, for instance. Those are all things that matter. In our electronic health record, we've tried to make use of this template Medicare Preventive, which captures a lot of the 4 M's. We're still struggling in getting most clinicians to adopt this strategy, but we feel that if this was, then we could very easily record and measure how much age-friendly healthcare how much of this 4M framework we're implementing. We're doing okay. At NSU Health, we've achieved level 1 certification, but our goal is to reach level 2 certification with the Institute of Healthcare Improvement. Our partners at Cano Health, which now has about 130 sites, have achieved level 2, committed to care excellence through the Institute of Healthcare Improvement, and they're doing extremely well. They're very tight control of their electronic health record. They're making all the physicians work through this age-friendly healthcare assessment before they can even move on. And every physician is being reported on every quarter as to how they're doing. And our third partner, Community Health Institute of South Florida, they've also achieved level 1 certification very recently in all their 10 clinical sites. So we have developed several resources. I just want to show you our website, which has, you know, streaming photographs and all our resources, our webinars, our podcasts are in there. So I invite you to look at that, and you will see a lot of education on age-friendly healthcare as well as general geriatrics. So some of our resources include the webinars that Denise Krushinsky has developed for residents and fellows, the hands-on training that we provide, and she provides at least once a week in our clinical sites. We have a geriatrics journal club 3 times a month, which is held on Zoom. And from our website, you'll see a series of podcasts that we've have 9 in all, but the final few are being, awaiting release. And then we've developed a virtual reality case highlighting the journey of Millie, who is our favorite patient. After she got a hip fracture from hypoglycemia, actually related to medication side effect, she fell, had a hip fracture, developed postoperative delirium in the hospital. And then the dilemma of what mattered to her and the selection of her living site and the assisted living center and identifying fall hazards in her new home is all part of our age-friendly virtual reality case. We've also incorporated age-friendly healthcare in a case discussion in our university-wide or health professions-wide interprofessional education days. So we're trying to infiltrate our education settings. This is just a snapshot of the 4M case, you know, where with special computers, 3D goggles, you can actually be in the room with Millie. You can look around, look at the hazards, look at the tools, and we're looking at the 4 M's as I described. And students have to answer questions at different stages and then as they work through the case. So that is awaiting release. Some of the problems we see in our setting, and I think different sites will have different problems, is that the time for medical visits is quite short, and medical complexity and the need for coordinating care is high. So even in the annual wellness visit, the time still goes with all the care coordination and dealing with multiple chronic problems. In South Florida, particularly, I think care is fragmented. There are different providers and specialists, and there is lack of ownership of patients. And I think there's still a little lack of buy-in into the importance of age-friendly healthcare. We find it's difficult to capture all the 4 M's at one visit. So we're trying to work on that. And also we want to talk to the Institute of Healthcare Improvement and other geriatrics workforce programs, and there are 48 in the country, have also had similar challenges. Patients also have some reluctance in accepting some of our discussions, especially those to do with advanced care planning. And of course, social determinants of health have prevented patients, having regular follow-up, and especially the annual wellness visit has often been sacrificed. And I think we need to have more communication and more reporting between our administration and clinical service managers who are tracking other measures of healthcare and quality with the practitioners. And one of our problems is, of course, a lot of the care, supervised care, is delivered by residents and fellows who are rotating frequently. So we need to keep training and retraining our practitioners. So the possible strategies we see moving forward are, as far as advanced care planning, which we're not doing too well, is to maybe incorporate the forms for advanced care planning, or the living will form and the 5 wishes form, keep that in the exam room, make that part of the annual wellness visit, or especially when there's a preoperative workflow, such as a preoperative visit going on. We could work with clinical informatics to modify the electronic health records, so practitioners need to complete the 4 M's before they can continue to move to the next stage of documentation. And I find some of the most successful health systems have done that. The annual wellness visit could be flagged more appropriately for age-friendly healthcare in the electronic health record. And I think we still need to do more convincing and to get more buy-in amongst our administration and clinicians. And we have interested students, public health students, other health professional students who could also follow and conduct quality improvement projects on age-friendly healthcare. And I think reporting our performance and holding clinicians accountable, especially those who are taking care of over 65-year-olds, could be beneficial. I thought of applying age-friendly healthcare to perhaps chronic conditions. And this is my take on age-friendly healthcare using the 4 M's on diabetes, which of course, as you know, can affect multiple systems, requires multiple medications. The risk of hypoglycemia is high. Treatment depends on the degree of complications and the prognosis. People with diabetes are often prone to dementia and depression and anxiety, and mobility is certainly affected by complications of diabetes. So I wanted to suggest that this could be a way perhaps that we could look at age-friendly healthcare in our more complex patients. So in summary, becoming an age-friendly health system has obviously financial benefits, but the most important benefits are intangible. We could make the world a friendlier and safer place for those venerated elders who are walking amongst us. And I think who we need to recognize and to value more, and to work on improving their quality of life. So I want to thank our South Florida GWEP team, and they're all listed here. Many are present here today. And of course, I want to thank all our patients who have worked with us, and to members of the geriatrics department. And thank you so much for your attention.
Oh, thank you so much, Dr. Pandilla. I know there are some questions in the chat and we will address those at our Q&A section
Okay.
after the last speaker section. Our next speaker is Jennifer Kwok from Kaiser Permanente, and I'm happy to share with you a little bit about her bio as well. Jennifer graduated from Columbia University School of Social Work in 2006. She worked in New York City in international adoptions and for a long-term care-based agency. In Hawaii, Jennifer has worked with children and families of all ages, including private and international adoptions, as well as medical social work in both the inpatient and ambulatory settings. She has been a part of an interdisciplinary palliative care team and ALS team at Kaiser Permanente and is currently a social worker in primary care. So welcome, Jennifer, and thank you so much for presenting today.
Thank you so much for the introduction, Isabel. My volume is okay. You can see my screen. Perfect. Thank you. So good afternoon, everyone. My name is Jennifer Kwok, and as Isabel shared, I am a licensed clinical social worker practicing in the outpatient setting in primary care with Kaiser Permanente, Hawaii market. I am based on the island of Oahu, and it is an honor to be able to share with you the work that I do with my elderly patients on a daily basis. Before we begin, I'd like to hear from you about what you think social work is. Many people have different thoughts about social work, some positive and some not so positive. When you think about social work, what word comes to mind? Use your smartphone camera to hover over this QR code, which will lead you to our survey question. And I am going to be able to pull up the survey results. Is it coming up for you guys on your end?
No.
No?
The QR code didn't open for me.
Oh, it didn't open for you. Oh, darn.
We can put it in chat.
Yeah, let me put it in the chat.
Thank you, Isabel.
I'll put the link so you all can access it through there.
Please let me know if that link works for you.
Yes.
Perfect, thank you. Oh yes, I do see some words popping up now, so thank you very much for that. It looks like help is a really big one, emergency situations, problem solving, troubled kids, finding resources, financial hardship, coordination of care, abuse, police, kids in the system, transitions of care. Yeah. Support and care. Great. Connect to resources. Therapist. Wonderful. Looks like people like the word problem solving. It's great. Homeless. This is really good. Thank you for sharing that. Because of time, I'm going to go back to my presentation, but thank you so much for everyone participating in that. All right. So thank you for sharing your thoughts on social work. As you can see, there are many different ideas of what social work is and what social workers do. I'd like to start with discussing what the social work profession is and what it is that we do. Many of you may have worked with or met a social worker in your various lines of work, or perhaps in your personal life. But what is social work? At its heart, the social work profession is a helping one. The National Association of Social Workers states that the primary mission of the social work profession is, quote, to enhance human well-being and help meet basic and complex needs of all people, with a particular focus on those who are vulnerable, oppressed, and living in poverty, end quote. We do that by focusing not just on the person, but the person in their environment. Social workers can be found in many different settings, including schools, prisons, healthcare systems, military, homeless shelters, and more. It's working with the individual person in the context of their environment. This environment could be contributing to stress, or maybe a support that the person can rely on. Social workers go through a lot of schooling and training to do this work. They can earn a bachelor, master, or doctorate in social work. There are also numerous certifications and licenses that social workers can earn through continuing education, in-person experience, and appropriate supervision. Some states have continuing education requirements that include courses in ethics, cultural competency, and others. Many clinical settings require at least a master's level social worker that is appropriately licensed in the state in which they practice. Like other professions, scope of practice is defined by the social worker's education level, licensure, and employment responsibilities. So why is social work important and valuable in the medical setting? There are many professionals in healthcare: doctors, nurses, medical assistants, lab technicians, dietitians, physical and occupational therapists, mental health nurses, and counselors. What can a social worker add to the skills already presented by this highly professional care team? I'd like to hear from you why you think this profession is necessary in the field. Same thing, use your smartphone. If it doesn't work, Isabel, are you able to post, copy and paste the link in the chat again for in
Yes,
case it doesn't work? Awesome, thank you.
of course.
It'll take us to our next poll question here. Are you able to see my screen? Because the answers are starting to pop up. So thank you for that. I see resources, assistance, bus pass, Department of Family Services, advocacy, complex discharges, patient safety, help, coordination, social needs impact health. Extend available resources to those in need, help patient navigate the system, better health and social outcomes. Yep, absolutely. Social determinants of health. Yes, absolutely. Safety issues, assure well-being. Wonderful. This is great. Thank you so much. So here are some things that social workers can do in the medical setting, in addition to the things that you all shared. We conduct thorough assessments to identify any gaps or needs. Our assessments cover a range of topics, including ability to perform activities of daily living and instrumental activities of daily living situation and safety assessment, social support and relationships, access to food and housing, financial assessment, and the impact of their medical conditions on their lives. In the medical setting, social workers provide support to patients experiencing an acute or chronic illness. This doesn't necessarily mean counseling or therapy. This could be a simple question. How are you doing with what the doctor shared? And allowing patients to express their hopes, worries, fears, and concerns. Of course, if behavioral health and therapeutic interventions are appropriate, we always refer if needed. Caregiver support is provided to the caregivers of our patients. I'm going to discuss this more in a little bit. We can follow up with a patient on a regular cadence to help with compliance with appointments and medications. This may involve referring to organizations that can assist with non-medical needs, such as transportation, in-home care, or home-delivered meals. We also make referrals as appropriate to community agencies to provide medical services, such as public health nursing and hospice. In the medical setting, social workers connect with physician, nursing, and other ancillary partners to communicate any pertinent updates or concerns. We also advocate for the patient's needs. We believe in self-determination and always starting where the patients are. Social workers address barriers to care and seek to empower patients with information and knowledge. I am a social worker that works specifically with our oldest and frailest population, those over age 65 with multiple medical issues. What I'd like to share with you is a model of care developed by Kaiser Permanente, Hawaii, and is being practiced on all islands in our state where there are Kaiser patients. This model is called SWITCH. SWITCH is an acronym, and it stands for Social Well-Being's Impact to Care and Health. As mentioned earlier, the Centers for Disease Control and Prevention have identified the social determinants of health that have found that where people live, learn, work, and play can have an impact on one's health. They are healthcare access and quality, education access and quality, social and community context, economic stability, and neighborhood and built environment. Kaiser's Care Management Institute decided to look at the social care needs of at-risk elders over a 6-month period. What they found was that there are 5 different factors that help shape someone's health that isn't directly related to their medical issues. They are purpose. Doctors Hill, Toriano, Mroczek, and Burrow published an article in the Journal of Research and Personality in December 2016, reviewing the value of a life filled with purpose. I'd like to read a portion of their introduction to you. Quote, having a purpose in life entails having a clear, long-term direction toward which to strive that organizes one's behaviors and sense of self. The value of having a purpose in life has been recognized for centuries as a variable integral to positive health and well-being. Adults with a greater sense of purpose tend to report better emotional well-being and physical health, experience less risk for cognitive decline later in life, and even enjoy greater longevity, end quote. Many people derive a sense of purpose from work. And one of the biggest life challenges or changes that our patients go through is retirement, whether it is voluntary or not. While some are happy to be retired, we know that working can give us a sense of identity and purpose. We have a more routine schedule. We feel that we are contributing to something bigger than ourselves. And hopefully we feel accomplished and satisfied after a hard days of work. But what happens after retirement? Some relish in not needing to wake up by a certain time or meeting deadlines, but that can soon give way to sleeping in, mundane activities, too many naps and too much TV, little to no stimulation, and not feeling useful or needed any longer. This lack of purpose or of feeling useful can lead to depression in many of our patients. In fact, the CDC reports in 2019 that 18.4% of adults aged 65 and older experience at least one symptom of depression. Now, this isn't to say that we need to have people work to keep or maintain a sense of identity. What is important is that people continue to have a sense of purpose in their lives. And this can be anything: traveling, providing childcare for grandchildren, volunteering at the library, or learning flower arranging at the local senior center. I have a patient who joyfully engages in a letter writing campaign to random strangers in the phone book as a way to witness to them. The second factor is isolation. Humans are by nature social creatures, and we all need social support in one form or another. The Care Management Institute found that many of our older patients are socially isolated, and a large contributing factor is retirement. They no longer have a work reason to interact with their colleagues, and maybe they don't want to bother their friends and families who are working or who lead busy lives of their own. The result is that their isolation can negatively impact their mental and emotional health, and even their physical health. Third is caregivers, whether there are any and how involved they are. Is it an elderly spouse taking care of your patient who maybe has their own medical issues? Or is it a child that lives a few hours away that just calls and checks in weekly? In Hawaii, there are many multi-generational households, which means there are children and grandchildren in the home, some of whom are able to provide some supervision, but often are busy due to work schedules and other priorities. A question to ask is how sustainable this caregiving situation is, especially after an acute event of either the caregiver or the patient. Or maybe the caregiver is burned out, stressed and overwhelmed over needing to provide care in addition to working or watching grandchildren. Caregiving is an intensely challenging job with little to no breaks and often little support. Not only that, but how will the caregiving situation change when the patient requires more assistance? Monitoring the caregiving situation for our patients is critical, because if something happens to the caregiver, what will happen to the patient? Money. Finances play an important role in a patient's social well-being. It determines whether you pay rent or eat, or pay co-payments for much needed medications. Can the patient afford to attend a senior center or daycare for social stimulation? How about hiring in-home care or moving into an assisted living facility? Do they have someone to help if they're not able to manage their own money or bills anymore? Are they falling victim to scams? Last but not least is medical or health trajectory. As medical providers, we have seen patients before with similar medical issues and diagnoses. We have an idea of what the patient may be facing in 6 months or 1 year or 5 years. But does the patient know that? And their caregivers and family? How would the patient's life and preferences change given this information? It's not just about prognosis. It's about knowing what the future may hold given certain medical issues. It also gives a patient a chance to voice how they view quality of life. Choosing dialysis may mean a delay in the inevitable, but it also means hours every other day spent in a facility. A liberal diet for someone with CHF may mean difficulty breathing and possible hospitalizations due to fluid overload. Ensuring that patients understand their current medical condition and what's to come provides for candid conversations about their choices and what's important. So now that we've identified key factors that can impact an older person's health, what do we do? Switch was developed as a way to identify the social gaps that may be impacting someone's care and to provide coordination and communication with providers treating the patient. One of Switch's main tenets is know me first, treat me second. On customer satisfaction surveys, many patients complain about how they didn't feel heard by their doctor. Perhaps they went in for one issue, only to feel that it was overlooked and the doctor instead focused on another issue. Patients see their providers for medical issues and possibly have a long problem list filled with acronyms and diagnoses. Clinicians are trained to identify what they feel is the most significant problem and to go from there. But soon we may lose sight of the person and instead focus on the diagnosis. Maybe we even identify patients by their diagnosis. But the reality is that every patient who walks through our doors or who speaks to us on the phone has a story. They may have a past that they consider to be their glory days, or one that was traumatic and full of pain. They may have hopes and dreams of the future, to finally graduate from college, to finish writing their book, to visit the home country they left many years ago, or to attend a grandchild's graduation ceremony. They are not just a patient. They are a veteran, a teacher, a janitor, a CEO, an immigrant, a survivor. I'd like to recognize that we all have internal biases based on our personal and professional experience of what we assume a patient would want. Using our professional judgment in assessment and intervention is what we went to school for and why patients see their provider. I was interested to see how organizations have begun to implement the 4M model in their practices. A quick Google search of 4Ms will lead you to organizations who believe in the 4Ms and have implemented some form of it in their assessments. This is wonderful, and many patients have benefited from this model. The implementation may include specific testing for mentation or a thorough assessment on mobility. What's in the What Matters section? I've seen a prompt for providers to review the Advanced Healthcare Directive and to discuss code status. I'd like to gently observe that this What Matters is from the medical care team's perspective. Patients may have a different idea of what matters to them. Dr. Pandya provided some wonderful examples of how to approach patients and exploring their goals. She gave examples of patients wanting to reduce the number of medications they're on and improve mobility and ambulation. I'd like to recognize that each member of the medical care team has a strength. And when those strengths come together, what you have is a supportive, collaborative team that can provide wraparound services for a patient in a timely manner. It may not be everyone's skill or comfort to talk with their patients in this way, to ask them what matters to them. But perhaps it is someone else's skill to conduct this type of assessment. Due to our skill and knowledge in conducting assessments, advocating for patients, and assisting with community resources and referrals, social workers were identified as key players on Switch teams. We performed thorough assessments with patients while keeping in mind the 5 factors discussed earlier. We engage with patients on a regular cadence, building rapport and trust with them as we ask them questions about their treatment preferences. And as we build this relationship, it usually reflects positively on the whole care team due to our close communication and collaboration. So it's not just Jennifer, the social worker, working with the patient, it's Jennifer from Dr. So-and-so's office. And thus the patient feels supported by the whole care team, even during these routine check-ins. Some like to ask our patients outright, what's most important to you? For those of you who feel like it's an awkward question, here are other ways of asking this question. What is the one thing that you want your healthcare team to know? What is one thing you're not willing to sacrifice for healthcare? What is a non-negotiable, the one thing you're not willing to give up? And what is so important to you that it may impact your healthcare decisions? What are we really asking patients when we ask them these questions? I like to think of it as, how do you define quality of life? I am sure you can think of patients who found it acceptable to have a tracheostomy and to be fed through a feeding tube, and others who didn't. Still others are insistent on eating certain foods despite repeated counseling on a more appropriate diet. The what matters question allows us to hear from the patient about what's truly important to them, so we don't make assumptions. But why ask the question? Why is it important to know how someone defines quality of life? The goal is to align medical treatments with patient preferences. Social workers believe in self-determination, that each person has a choice and should be empowered to make their own decisions if they're capable. We may not agree with their decision, but it's not our decision to make, despite our good intentions for that person. In medicine, there has been a shift from doctors' orders to shared decision-making. Providers are now inviting patients to take a more active role in their healthcare, such as deciding on whether or not to take a particular medication or undergo surgery. When we know what is important to a patient, we can offer treatments that would support that patient's priorities. For example, if a patient has a specific event or milestone they wish to reach, such as a graduation or an anniversary, sometimes they will elect for a curative or more invasive procedure just to get them there, like maybe a third line of chemo. Another example is if a patient says it's really important for them to live at home with their family, then a trach and peg may not be the best option for them. And you may have to have a conversation around other treatments that will allow the patient to be at home. So let's all put this into practice. You will be broken out into breakout rooms, and I'd like for everyone to take turns being yourself in your professional role about to meet your next patient. Role play speaking with your patient using the know me first, treat me second method. Here's a very generic scenario for you to role play. 85 years old, past medical history includes diabetes, CHF, non-compliant with medications and diet, hospitalized 4 times in the last 12 months due to fluid overload, has trouble walking and seeing. As the provider, talk to the patient about what you see as being their trajectory and how you can assist. For example, the patient may have more frequent hospitalizations, more medical issues relating to ambulation and vision, and likely needing more help in the future. Focus on what you'd normally talk about in these type of appointments based on your discipline, but see if you can use the know me first, treat me second, and what matters most concepts. You'll be randomly assigned to a breakout room with one other participant. Have one person play the provider and one person play the patient. We'll give each pair about 8 minutes and then reverse roles. When we come back, I'd like to hear about your experience as both the provider and the patient. Isabel or Janice, are you able to break everyone out into their breakout rooms?
Yes, we
Awesome.
are. What we're gonna do is we're gonna put you into different groups, and then we will give it about 7 minutes for the breakout session, and then we will break it up.
Thank you. Isabel, are you able to see if everyone's joined their sessions or breakout rooms?
I'm trying to see, Janice, you are the one, I see everybody is
They're
assigned.
in their rooms. Okay.
So,
Hi, this is Dr. Mojo. There was nobody in my breakout room. It was just me.
Let me see.
I was in breakout room 4.
Oh, because they haven't joined. Let me see. Janice, are you able to put Erica and Jacqueline in room 4?
Yes, let me work on that.
Thank you.
Or maybe put those two together on other rooms.
Is there anyone else on the line who hasn't been able to join a breakout room?
I'm going to put Dr. Mohol into another room, so that'll be a room of 3.
Hi, it's still just me in breakout room 4.
I'm showing you as not having joined breakout room 4, but I'm
I-
going to move you to room.
I came out, but I was there.
I'm going to move you to room 8. You'll be in a group of 3.
Okay, thanks.
Thank you, Janice. Are they all in now?
I guess those that have joined are, we just have a few who did not join, but that's
Okay.
fine.
That's fine. Yeah. I wanted to ask about timing because I did say have everyone like pair off, and I wasn't sure what time we should bring them all back. How much time do we have left?
We're going to bring them back in 4 minutes at 1:20. It's we have 10 minutes left. Well, we have 15 minutes left. So we'll bring them
Oh,
back.
okay.
Yeah.
Okay. That's good to know. Okay.
All right.
I'd like to debrief with everyone about their experience after.
Okay.
And I'll try to fly through my next. I only have a couple of slides, so I'll fly through.
All right. Sounds good.
Thank you.
Mhm. Jennifer, we've closed the breakout rooms and everyone should be returning in about 30 seconds.
Thank you. Janice, will I know when they're all back? Should I just start talking? I don't know.
Yeah, you can just start talking.
Okay.
Yeah. Mhm.
Okay, perfect. Well, welcome back, everybody. I hope that the breakout rooms were helpful for you. I'd like to do a really quick debrief and hear from you from the provider's perspective. What did you learn and how was this different or similar to how you approach your patients? Feel free to unmic yourself and just verbally share with us what your experience was.
I had a great social worker, Sonny, and maybe she can talk about it.
Oh, thank you. Yeah, it's always a really good experience to kind of be able to role play this. And I know Dr. Pandya has heard a lot of the things from the patients that she was able to say, so to be able to kind of practice it in a realistic but lower stakes setting is always nice.
Awesome.
Yes. So I was complaining about, not seeing the point of it all. Getting around was hard. I couldn't see my friends. I wasn't seeing my daughter that much or the grandkids. And Sonny gave me some ideas on, transportation and how to get services so I could meet my friends, and also maybe reach out to family and not feel that I was being a burden. So that was helpful.
Awesome. Wonderful. I'd like to open it up to those of you who are patients as well. What was your experience and how was it for the provider to be asking you these types of questions?
Well, for me, this is Shweta, and I was the patient and my provider was Robin Sandhouse. So it was like a perfect combination.
True.
And somehow it just came intuitive to us because she's used to being the provider, and I guess I'm used to being the patient most of the times. But so we had a great discussion and we were able to integrate the 4 M's. Like, she asked me about, why I'm there, what's bothering me. And she also tried to kind of, dig into, some of the correlations, like why certain things are happening. Like we talked about my mobility issue, because in this scenario, this 85-year-old has mobility issues. So we talked about my mobility issues and how my mobility issues are actually impacting my daily life, and some of the reasons around for that case. So we talked about that. Robin, do you have anything to add there?
Yeah, it really was really nice. We did try to go in with the 4 M's, and it was interesting. I kept trying to go back to that as the practitioner, saying, okay, so what's bothering you, physically, but also how is this impacting you? What matters to you about this? And so it was great. What I was like, well, the physical thing is this pain she's having. But what's really mattered to her most about that was that it was impacting her abilities in her home to care for her spouse, and her doing her, in the kitchen, her cooking, which meant a lot to her. She was concerned about medications that she was on, that maybe this had something to do with it. But then she also was saying her vision was impacting her, and that she was trying to change her diet because I think the patient was also diabetic. And so it was really great exercise, I thought.
That's wonderful. Wonderful. I'm so glad to hear it. And I agree with the person who shared earlier, Sunny, I think it was you, when you said it's kind of like a safe low risk environment. You're with colleagues here. So that's really nice. We can practice the words in our mouth, until it comes more fluid and natural to us. So that's wonderful. Just given time, I'm going to move us on, but I'd love to hear from you later about how this exercise was for you. So as you can see, this is really in-depth work, and it can't just be one person who does all these assessments and has these conversations with patients. Ideally, there is a care team who knows the patient well and can support them. Many care teams include doctors, nurses, and pharmacists. Some may also include others, such as physical therapists, dietitians, and behavioral health therapists. I believe that social workers are an integral part of the team. Our job includes getting to know the patient, finding out what matters to them, performing psychosocial assessments, referring them to resources, helping them identify and express their medical preferences, and providing case management. We take this valuable information and pass it along to the rest of the team. I hope this gives you a taste of how social workers can be integrated into your clinic setting. Mahalo for your time and for the malama you've showed towards your patients.
Thank you so much, Jennifer. That was such an amazing presentation. And for all of our participants, this is Jennifer's contact information. And you will also notice that she does have our knowledge survey QR code on her final screen. So we will also have it on our final slide, but if you can take a moment to scan the code right now so it can open up on your smartphone, on your tablet, because we really would like your feedback on today's session. And we do have a couple of other closing remarks. So I first want to know if there were any additional questions. And Dr. Pandya, we did have a question for you during your presentation. And that question was, are there guides or other tools, to help providers address and discern what matters?
So thank you. I think a lot of it was also addressed by Jennifer. I think what matters is actually an open-ended issue, and different systems might have different tools or different places you can document, but there has to be ability to have flexibility. I don't think it can fit into a cookie cutter type of tool, but the Institute of Healthcare Improvement site has a lot of guidance and position papers, and they look at other things that matter, length of hospital stay, what are the, what are the patient's priorities, surgical infections, health-associated infections, and then open-ended questioning on what matters to you, as Jennifer talked about. And they also mentioned shared decision-making, because sometimes you're really working with the patient to arrive at, okay, what are you willing to give up? What are you not willing to give up? And I think what matters, the concept should also include health equity. And so again, the IHI website is a good resource for position papers on that. They have something called the Better Care Playbook. I haven't looked at that in detail, but that actually will outline, what encompasses better care, what is better care. And then they have an initiative which has really taken off, is 100 million people living better lives. And they have a resource library under that. So I don't think that this should be a prescriptive approach on what matters. It could just be advanced care planning. It could be simple things about quality of life, about function, about medications, about access to healthcare. So yeah, that's my opinion.
Thank you so much for that, Dr. Pandya. I don't see any other questions in the chat, and we are at 2 minutes until our wrap-up time, and we really want to be respectful of everyone's time. Actually, one more. Thank you so much for your comment, Amy. Once again, this is the QR code for our evaluation and our knowledge survey. We would really appreciate it if you would take the time out to complete this survey. It's very brief, only a few questions. It won't take much time, but this data really does help us plan for future sessions and to help assess what training needs that we have for our providers. Next up is our June 1st session, which would be the patient side of age-friendly health systems. And we have some dynamic speakers actually from the Institute for Healthcare Improvement and Rush University. Both will be talking about how patients play a role in the 4M framework. And if you have not registered for that, which I'm sure you all did, please do so. And also please share this training series with your colleagues as well. We would really greatly appreciate that. For those of you who attended today, you will receive a certificate of attendance. Nurses will receive continuing education credits for this. And if you have any other institute where you get professional development training credits for, you can use this certificate to show that you did receive an hour and a half of training for today. So thank you so much once again. Here is all the contact information from the speakers for today. And as stated earlier, we did record this session and we will upload this to our YouTube channel. Thank you so much, and we hope you all have a wonderful day.